Hi, I'm Randy Guy, Commissioner President of St. Mary's County, Maryland, and you're tuned in to MACO's Conduit Street Podcast. Whether you're a Maryland resident, a government official, or just someone interested in learning more about public policy in Maryland, this podcast is for you.
Hello, and welcome to the Conduit Street Podcast. This is your super substitution, Sarah Sample from the MACO policy team, and I'm once again stepping in today for our regular hosts, Michael Sanderson and Kevin Canale. And today we are going to discuss a very timely topic, which is where we are on COVID-19, especially as we venture deeper into another winter. And one major thing is different. This winter, we are officially outside of the federal state of emergency. And this is the first time since 2020, I believe it is. So joining me today, we have a very special guest. We have Dr. Lawrence Polsky, who is the Calvert County Health Officer. So as our audience has undoubtedly heard before, the health officers are the local officials in every county that ensure the core tenets of public health are being met. And a very significant part of that role focuses on preventing infectious disease. So welcome, Dr. Polsky.
Well, thank you, Sarah, and thank you and Michael for extending the invitation. It's great to be back with you.
Absolutely. We are so excited to have you. And just for our audience, how long have you been with the Calvert County Health Office, like as the health officer?
Now, if I think through the COVID haze, it's now been 11 years over here.
All right. So you were there through the beginning of this and now coming out the other side. So that's a wonderful perspective we're excited to have. And so the major areas that we want to cover today are what the current climate is on COVID-19 and preparedness. So, things like vaccines and testing, and then also how policy can affect those goals and outcomes. So does that sound good to you?
Yeah, no, that sounds fine.
All right, great. So I guess first we'll dive into sort of the topic of post-pandemic climate and preparedness. So why is this climate we're in right now different from when we were in the emergency phase? Like what's fundamentally changed here?
Well, certainly a lot has changed. And you think about how much we've learned over the past 3.5 years now. So I'll flip through maybe what I think are some of the most important things. And I would start out with the vaccines that we have available that in those early days of COVID, when hospitals were overflowing and people were emotionally very tense about what was going on. Now everyone has a chance to protect themselves with vaccination. And we should keep in mind that vaccines do a very good job of protecting us both from acute infection and also decrease our risks of long COVID. And as the COVID virus continues to mutate, staying up to date on vaccinations is really essential. Vaccine formulations that were recently released, and I'm sure that most of your listeners heard about 2 weeks ago, the FDA and CDC were approving a new formulation. Those new formulations produce antibody levels about 4 to 10 times greater against the strains of COVID currently circulating than our previous vaccine formulation.
Wow, that's a great jump. And does that help with the prevention of long COVID as well?
It does. And we have now multiple well-done studies that show that people who are up to date on their vaccination not only are much less likely to get sick, but even if they end up with a mild illness, that they are much likely to end up with persisting symptoms. And as a reminder, long COVID can take several forms. For some people, it's more quality of life issues. They feel chronically fatigued and really significant fatigue, where it's hard for them to get to work, for children hard to really concentrate and focus in school, clouded thinking. And then the other aspects of long COVID can be serious illness. So we now have multiple studies. A recent one just came out of the VA that showed that people are diagnosed with new onset diabetes at more than double the rate in the following year after COVID than those who have not been infected with COVID. So the prospects of vaccine is, again, not only that initial illness with COVID, but also the long-term effects.
Right. And those long-term effects, those long COVID effects, I mean, that sounds like it doesn't just affect you every day, but it affects almost the things that you're going to do every day, like even just the simple things. So that's rough.
Yeah. And again, for parents to keep in mind that although children are not as likely as a percentage of those who get COVID to develop long COVID, still the studies that have looked at children have shown about a 5 to 7% incidence of long COVID symptoms, even in kids.
Oh, wow. Okay. Well, that's really important to know, especially as we're going into another flu season. And so, before we start talking about this season, where COVID-19 was concerned last year, what did that flu season look like? And what do we expect this year?
So last year, our flu season was actually relatively mild, but each flu season is really different. One year, we can't predict the next. It's important to know that this year's flu vaccine looks like a good match based on the studies out of Australia and South America, where they're now coming out of their flu season. So keep in mind that in the Southern Hemisphere, everything is flipped.
Oh, right.
Most of the time, the strains that are circulating in the Southern Hemisphere in what is our summer migrate up north, and that becomes our predominant virus strains in our winter. So with a vaccine formulation this year that looks like a good match, very important for people to take advantage of getting vaccinated, not just against COVID, but also against the flu. And I'll throw out a quick reminder to business owners that viral illnesses increase employee absences. And if employees come to work sick, they're less productive and they make more mistakes. So there's not only a health incentive to prevent both flu and COVID infections, but also an economic incentive to keep employees healthy. So aside from the direct medical costs, seasonal influenza costs the Maryland economy about $150 million each year, mostly as a result of decreased job productivity. So I would encourage business owners and managers to incentivize their employees to get both flu and COVID vaccines, allow staff time off if they become ill, because it's certainly better to lose one employee for a few days than have most of their shift mates out for days or even a week, a few days later.
So really boosting that accessibility, but also doing it now or even a month ago, just because the worse it gets, the harder it's going to be to get that time away.
Absolutely.
Especially as you have more and more people who are catching it. So another thing, and that's interesting what you say about Australia, it's nice. I mean, I didn't think about it that way, where you sort of have a bit of foreshadowing for how, and some of what of a forecast for how our winter might look. And I never considered that was really giving us a glimpse into the future, almost in a way.
Right, and that's how they, when the FDA, CDC, and the vaccine manufacturers decide on which strains of flu they'll base that year's vaccine on. Because keep in mind that for the flu vaccine, it changes every year. They take a look early in the flu season in the Southern Hemisphere and start doing their modeling, making predictions. Some years, unfortunately, the flu strains continue to mutate, and it isn't a good match. But again, this year looks like a very good match.
Right. Well, so then I guess also when it comes to the vaccines, give our audience a little bit of an example of the kind of the dangers or the sort of catastrophic scenarios we're trying to prevent. I mean, this year and every year when it comes to a highly transmissible virus and how that can weigh on resources.
Yeah, so even before COVID appeared, we've had many winters in Maryland where hospitals are overflowing due to flu and RSV cases. Maybe we'll talk a little bit about RSV during the course of the interview. And I spent most of my career before I switched over to public health as a regular day-to-day physician, taking care of patients both in the office and in the hospital. And there were years where surgery cases had to be canceled because there was no room in the ICU. There was no room up on the floors. So every year is really roll the dice in terms of severity of influenza strains, how severe RSV is going to impact that year. And now with COVID added on top of everything, there's even higher probabilities of maxing out emergency rooms and ICUs. So, it's really important to keep in mind that influenza, RSV, and COVID all stress people's bodies. And not only the direct illness, meaning pneumonia from influenza or COVID, but also these illnesses increase the risks of heart attacks, serious breathing problems, strokes, other medical complications that require emergency room and ICU care. So the more we do as a community to minimize transmission of viruses, really the safer we all are. And I'll just add really quickly that regardless of how healthy any of us are, we're all just a car crash or an infected appendix away from needing a hospital admission. So it's really in everyone's interest to have local hospital resources available when we need them.
Yeah, especially when you think a little bit about resource depletion and how we can avoid that, because those car accidents are still going to happen. And so when you have too many of the resources being sapped up, then you sort of have this chain reaction where things that are not easy, but we're able to deal with because we have the capacity, that becomes more and more difficult. So you have people potentially suffering exacerbated circumstances for something that wouldn't have been as difficult to deal with if we didn't have as much of that weight on the resources. And essentially that's what the vaccines can help us avoid.
Absolutely. And you think about if your local hospital is at capacity and something life-threatening happens to you or a family member, and the ambulance has to divert to another county or across a metropolitan area, that extra 20, 30 minutes to get to another hospital, could make a life and death difference. And
Absolutely.
We also, I think in every community across the state, we're dealing with worker shortages in hospitals, in nurses, respiratory therapists, physicians. When we have unnecessary admissions in hospitals, that just further stresses and strains the staff that are working in every hospital across the state.
Definitely. We need those people there to make sure that the care can be executed. So you talked a little bit about the vaccine so far and how they're different, but maybe you can explore that a little bit more. So can you explain how these vaccines differ from the original versions that were used during, like, let's say the mass vaccination process? I mean, you more or less were saying they're updated and they're being updated, consistent with what strains we're seeing elsewhere. Is that the case?
Yeah. So the COVID vaccines, I'm sure people recall that the vaccines that we mostly use are what are termed mRNA vaccines. So it's a different technology than flu vaccines. People get vaccines for tetanus. There was, I think, some misinformation in the early stages when the vaccines were being rolled out that somehow this was just some abrupt new thing out of the blue. mRNA technology was gradually developed over about 30 years and fortunately came into prime time just as COVID appeared. And so the mRNA vaccines, the production of the vaccine is much different. Older vaccines, oftentimes they would have to inoculate chicken eggs, other sorts of formats were very kind of labor intensive and had impurities in there. With this technology, the scientists are actually able to take a small bit of mRNA or messenger RNA from that correspond to the surface proteins, or I think most of us are familiar with spike protein now. Mm-hmm. The spike proteins for COVID vaccine, for the COVID virus, unfortunately have it turned out to be a very malleable part of the surface. So as we see new variants pop up, there are sometimes subtle and sometimes more abrupt changes in the structure of that surface protein or that spike protein. As a result, the vaccine that was developed a year or 2 years before, it doesn't quite bind on and neutralize the virus as well. So with the new vaccine, what they've taken is the corresponding mRNA from the most recent set of variants, the XB family of variants. And so, as I mentioned earlier, when they tested these new vaccines for the about half dozen predominant strains that are circulating right now, the antibody levels that were generated were anywhere from 4 to 10 times higher than with the bivalent. So we're now on generation 3 of mRNA vaccines. And so the beauty of these mRNA vaccines is that it is relatively easy to continue to update to match what is circulating. So the anticipation is that probably once a year, we'll end up with a new formulation, same technology, just a new formulation that best matches and best neutralizes the strains of COVID that are circulating.
Got it. Well, so one thing I've been reading about, as it relates to sort of updating the vaccines is something called Novavax, I want to say it is. And so, and I had read that it's not based on the mRNA, I want to say it's something else. But how does that fit into the equation? I'm sure our audience members have read about that as well, because I've seen it all over the place. Can you tell us a little bit about that and how it fits in?
Yeah, so there were 2 other vaccines that were available earlier, in addition to the mRNA, which the Moderna and the Pfizer are the mRNAs. So one was Novavax and one was Johnson & Johnson. The Johnson & Johnson has essentially been taken off the market. It turned out to just not be as good of a vaccine. Novavax is actual spike protein. So the mRNA vaccines, when that's administered, it actually prompts our immune system, or our cells, I'm sorry, not our immune, our cells to produce its own spike protein. And then as a result, we internally produce antibodies.
Oh, so it's like an immunobooster in a way.
Well, sort of. It's just a different way of getting the spike protein itself into the body. And so Novavax directly has the spike protein as opposed to prompting our bodies to manufacture it.
I see.
The issue right now with Novavax is that it is still pending FDA approval. And so the FDA generally doesn't comment as to why they haven't approved a vaccine at that point. Last year, there were some issues with the production facility. There was no problem with the safety of the vaccine, but there were some issues with the production facility, and that just delayed release. So it's unclear at this point whether they're still revamping at their production facility or something else. So I can't comment about the effectiveness of the Novavax vaccine because we just don't have the data at this point.
Got it. Well, so then for the vaccines that we do have and the boosters, so if I went to I'm in Anne Arundel County, if I went to the local health center in Anne Arundel County, is there a cost for the vaccines?
For everyone with insurance, regardless of what kind of insurance you have, whether it's Medicare, whether it's state insurance, Medicaid, or a commercial insurer like Care First or Aetna, there is no out-of-pocket cost for any of the COVID vaccines. And I'll say same for the flu vaccine as well. So for anyone at this point who is going to schedule an appointment, they don't have to worry about payment for that. For people who don't have insurance, there will now be full out-of-pocket cost. So the federal government stopped purchasing the COVID vaccines, I think it was around spring. And so with the release of these new vaccines, for the first time, they will be paid like any other vaccine that you would get. It would go through your insurance.
Got it.
Because of the, essentially, people were saying the COVID vaccines were free. We all know that, it was our tax dollars at work.
Yeah.
But regardless, whether you had insurance or didn't have insurance previously, no one had to pull out their insurance card. Nobody had any copay. So people without insurance had no barriers to getting vaccinated. Now, if they go to the pharmacy, it's about $125 a dose, which is going to be prohibitive for some people.
Definitely.
But we're both at the state level and federal level. It's a work in progress as to how to make vaccines affordable for people who lack insurance.
Got it. Well, so on the subject of the flu season generally, and you'd mentioned this before, so obviously COVID has been the topic of, conversation for us so far, but it's not the only virus that fills hospital beds in the winter. So there's been a lot of talk about RSV that you had just mentioned earlier. So let's talk a little bit about that. But first of all, what's the acronym? Is it respiratory syncytial? How do I say this?
Yeah, that's very good. Yeah, respiratory syncytial virus. So.
Okay, got it. So talk a little bit about what people should understand about RSV and what they can do to keep their children and themselves safer.
Right. So RSV is, for some reason, just flown under the radar as far as general public being aware of this. But certainly it's a virus that for many, many years has taken a significant toll. So and
it was talked about a lot last year. I feel like that was one of the first times I remember really seeing it everywhere.
Right. So and this, like influenza, is typically a late fall, winter virus, although sometimes there's a little bit of variation. And on an average year, there are about 60,000 hospitalizations across the U.S. just among children under age 5 as a result of RSV, and about 200 pediatric deaths each year. RSV is actually the leading cause of hospitalization for children below the age of 2. And what you reference is hearing it for the first time last year. That's probably because there was really a crisis in pediatric hospital beds across the state. And this was due almost solely to RSV cases.
Wow.
On the other end of the age spectrum, meaning for those 65 and older, annually there's actually about 100,000 hospitalizations due to RSV and about 8,000 deaths. So I can talk a little bit about the vaccines and the other new aspect is what is an antibody inoculation. So I'll try to just briefly go through that.
Yeah, I saw an article about this. So yeah, I'd love to hear your perspective on it.
Yeah, so RSV vaccines at this point have only been approved for those 60 and older and for pregnant women, particularly in the third trimester. They are currently doing research to see how appropriate the vaccine would be for those under 60, particularly people with chronic health problems who are more likely to end up being hospitalized. So that is something to keep an eye on for anyone who's listening, who's under 60 and has diabetes or has chronic heart disease, kidney problems, that it's possible, and I would say likely, that RSV vaccines will be available for them probably sometime over the next year, maybe not in time for this season. And pregnant women, the reason that approval was made by the FDA is that when a pregnant woman gets a vaccine, whether it's a flu vaccine, in this case RSV, COVID vaccine, the antibodies that she produces, some of those antibodies travel through the placenta, through the umbilical cord, and into the baby. So that when the baby's born, that child will have circulating antibodies, which last for about 6 months, which is around the time, not so coincidentally, around the time that the baby's immune system really starts to move more into gear.
Wow. So it gets a head start in a way.
Right. So I didn't mention that vaccines have been approved for children, even though I just said that the leading cause of hospitalization for children is RSV. And that's because at the moment, what the CDC and the manufacturers are going with is an antibody inoculation, so a monoclonal antibody. It's a little bit confusing the way it's been explained, because they just talk about it as inoculations, which I think for most people, they think about as a vaccine.
Yeah.
The difference between them is a vaccine is something that is then stimulating our immune system to produce its own antibodies. And there are additional aspects of the immune system, which I don't want to give a whole lecture on how T cells work and all this kind of stuff. But vaccines are prompting our body to mount an immune response. What has been approved for young children are actual antibodies themselves. It's a long-lasting antibody formulation. It lasts for about 5 months, and it's recommended for anywhere from newborns up to age 8 months. And then for children who have significant underlying health problems, for children who have congenital heart conditions or cystic fibrosis, then it's approved up to about 1.5 years for those children. So the antibody shot is about 80% protective against illness that's serious enough to require a doctor's care, and about 80% effective against hospitalization. The issue right now is that not a lot has been produced, and there's also a payment issue at this point.
A limited supply.
And the insurers haven't completely worked out how they're going to pay for this. So for, again, any new parents listening with very young children, they can check with their pediatrician. I just can't guarantee that the formulation will be available to them for this season. For Medicaid, there should be no cost barrier. And so for anyone who has Medicaid insurance, or their child has Medicaid insurance, they should be able to get the inoculation if it's available. They should be able to get it without any cost at this point.
Interesting. So basically, if I'm getting this right, what you're sort of explaining is that instead of something where it's telling the body to produce X, like to produce the antibodies, they're essentially getting an antibody that their body will then be able to start to replicate.
So they don't need to replicate anything. It's actually that now we have the technology to be able to produce in the laboratory, to be able to produce antibodies in mass quantities.
Got it.
And then so that the injection itself is purified antibody. And again, that will circulate in the baby's system for, research has shown, for a good 5 months. So if a child gets that inoculation, let's say in early October, then that child will be protected through the end of February, maybe a little bit into March, which, again, typically RSV is most prevalent in the fall and into the winter.
Right. Okay. Well, so then that's the viruses that we're super worried about. So let's maybe switch to the policy side and sort of the regulatory side of this conversation. So federal, state, and local cooperation, between those three, there's a bit of an ecosystem here. that is intended to fulfill the public health mission, especially as it relates to infectious disease. So what is collaboration like with, let's say, the Maryland Department of Health at the state level, and then the locals? Like what should that prevention strategy look like as far as how we can collaborate with them? And is there guidance coming down from the state?
The Maryland Department of Health has been following CDC guidance for COVID-related issues, which makes it easier for us at the local level. We don't see, conflicts between policy there.
Got it.
Local health officers meet at least monthly with our colleagues up at MDH, and I'll say that I talk to my other health officer colleagues on a very regular basis. We all have discussions with experts at University of Maryland School of Medicine, Johns Hopkins, our local infectious disease specialists, and staff at our local hospitals. So it's clear to all of us that the landscape can change at any time, and communication between state and local officials and between local partners is really critical to best safeguard the members of our community.
Yeah. Well, so, and then from the federal perspective, is it sort of that same sort of chain link where the federal agencies are communicating directly with the state and then the state is filtering that down, or is there local county collaboration with some of the federal agencies that are working on this?
So there is certainly communication between the federal level and state, each of the states. Also, the CDC makes accessible to health professionals, including each of your local health officers, makes information directly accessible. And I know that I regularly join calls that the CDC hosts with infectious disease experts from around the country. And so federal communication is both via the state down to local levels, but also directly from federal to local level.
Got it. So the best case scenario is for the state. So it sounds like the CDC sets the guidelines and the state and local sort of work together and collaborate to make sure that the guidelines are carried out. And that's sort of what it should look like. Yeah.
And as we're discussing, really communication is paramount. And I mentioned a little bit before about a program to try to help people without insurance be able to access COVID vaccines. So that's, some people may have heard, referred to as the Bridge Access Program. So that's a good example of how the different levels, federal, state, local, are trying to work together. The federal government is in the process of shipping vaccines out to each of the states. The states in turn are then allocating out to the local levels, and then on the local levels for health departments, possibly for federally qualified health centers as well. They'll have limited amounts, but they'll have vaccine that they can provide to community members.
Got it. Yeah. So Bridge, it's sort of filling that gap in access for some populations.
Yeah.
Right.
And I can take a minute just to add about communication. I think it's really important, both at state level and local level, that health professionals, public health professionals in the private sector, that we're communicating with residents and business owners across Maryland. I think there's just been so much misinformation, some of it malicious, that it's important for people to have trusted sources they can turn to when they're uncertain about, what they're seeing or reading, especially when it comes to social media. So aligning state and local messages in formats that people can really understand, not just a bunch of medical jargon, but something that people can really appreciate.
Flow charts and things.
Yeah. It's going to go a long way in helping people make better decisions about their health, the health of their children. And ultimately, from a public health standpoint, that's what's most important to us, is that we're really the conduits of helping people take good care of themselves.
Yeah. Well, and I see too, like the point you were making about the businesses. I mean, there's obviously an economic impact, but also if you're communicating effectively with some of those small and larger businesses, you have the potential for them to be hearing, a larger audience to be hearing the information at one time, but also the potential that it's the second time that they're hearing it if you're communicating with residents and with businesses that are also communicating with residents.
Absolutely.
So it doubles down on that communication effort. So it makes a lot of sense. So then I guess, leading into this winter, I mean, do you feel like we're prepared? We're ready to go?
Well, we're certainly in a lot better position than we were in the past. And the one thing that worries me a bit is that people become a bit apathetic, that last year wasn't horrible. We still had a significant number of deaths. COVID still filled a lot of hospital beds, but that people can just sort of take it for granted that things are naturally just going to continue to get better. That's not necessarily the case. So I really would encourage people to take advantage of the updated vaccine. I got mine last Thursday, and no side effects. A little bit of a sore arm, but that was about it.
Yeah.
And I got my flu vaccine the week prior.
Right.
So, take advantage of that. And then all the things that we've learned, again, I would hate to see that go to waste.
Yeah,
So,
or slide backwards, so if we stay vigilant, then we're less likely to have sort of a backslide in terms of how much progress we've made this far.
right. So, wear a face covering when you're in a high risk setting, especially as we move into the late fall, winter, when viruses are going to be at higher levels across our communities. And when we do get sick, staying away from other people so we don't end up inadvertently spreading it to people who are more vulnerable.
Exactly. So, and then I guess, another question I would have for you is, so obviously get the vaccine, get the booster, make sure we're protecting ourselves, but then where is the state and the locals on masks right now? Is it pretty much, do what you think you need to do and be responsible?
I would be surprised at this point if we see any mandates.
Yeah.
I think barring a variant that would significantly evade the vaccines we have, which fortunately at this point we're not seeing, and that same variant being very pathogenic, meaning that it induces very severe illness, I can't really foresee us going back to a point where there are mandates. I think it's more personal responsibility at this point. And again, being conscious of the well-being of your neighbors, your coworkers, and doing your best to not inadvertently get other people sick.
Absolutely. Well, thank you so much for joining us today, Dr. Polsky. I appreciate you being here. This is priceless information for our audience.
Absolutely, my pleasure.
All right, gang, let's wrap up another podcast. If you enjoy the content you have heard today and in other episodes, then please subscribe. That way you will receive all the episodes directly to the device of your choice. And if you're feeling up to it, give us that 5-star review to let others know what they're missing out on in the world of local government policy and practices. You can also keep up with Conduit Street content on social media, including Facebook and X, formerly known as Twitter. But the URL is still twitter.com. X.com is only a redirect, so maybe we're still calling it Twitter. Anyways, and last but not least, check out the Conduit Street blog. For Dr. Lawrence Polsky, this is Sarah Sample signing off, and we will talk to you soon. Stay safe out there.